Okay, so good afternoon, everybody, and thank you for joining this meeting. And thank you also to all the people connected online. So for the few of you who are not yet familiar with our organization, I would like to mention that Cittadinanza Attiva is an organization founded in Italy in 1978 that promotes citizens' activism for the protection of rights, the preservation of common goods, and the support of people in vulnerable conditions in Italy and abroad. In particular, since December 2001, Cittadinanza Attiva has been working on a daily basis, not only at the local level and the national level in Italy, but also at the European level, thanks to its European branch called Active Citizenship Network. Which is one of the most widespread and flexible European networks, which in recent years has been able to involve in its initiatives hundreds of civic organizations, patients, and consumers from European and non-European countries. As you have already seen from the program, both today and tomorrow we will balance informative moments for which we have invited independent experts with advocacy moments. This is a hybrid event, and we will have some speakers as well as some representatives of association connected online. So as you know, today and tomorrow, we will be focusing on vaccine-preventable respiratory diseases. And in particular, today's meeting will be entirely dedicated to COVID and long COVID syndrome. COVID-19 has a major economic, health, and social impact in the countries of the WHO European region, affecting hundreds of millions of people. Although the acute phase of the pandemic is over, COVID-19 has left its mark on healthcare systems. And high rates of burnout and COVID-19 related diseases among health workers have caused workforce dropouts, exacerbated staff shortages, and increased waiting times for patients to access services, and required health services to treat people with persistent symptoms after acute infection. These medium and long-term debilitating symptoms are collectively known as post-COVID condition, or commonly long COVID. The WHO defines this condition as the persistence or development of new symptoms 3 months after the initial severe acute respiratory syndrome infection, with symptoms lasting for at least 2 months without any other explanation. 1 year after the end of the pandemic, prevention, immunization, and treatment, together with adequate information, remain essential to continue the fight against COVID-19 infection, especially when it threatens the most vulnerable populations. So we will have the opportunity to discuss these issues in more detail with the experts we have invited. And before handing over to them, I would like to do a quick tour de table to get to know each other better. So please tell us your name, the name of your organization or institution you represent, and the country you come from. So let's start with the people in the room and then move on to the people connected. My name is Bianca Ferraiolo, and I'm the head of office for Active Citizenship Network here in Brussels.
Mariano Botta, Responsible European Affairs at Cittadinanza Attiva and Director of Active Citizenship Network.
Hi everyone, Daniela Quaggia from Active Citizenship Network.
Good afternoon, everybody. I'm Stephen McMahon. I'm chairman of the Irish Patients Association, which is a patients' rights, patient safety, cross-disease advocacy group.
Good afternoon. My name is Maria Pechter-Pateda. I'm from Austria, and I'm from the Niederösterreichische Patienten- und Pflegeanwaltschaft, we are agency for patients.
Good afternoon. My name is Marleen Stroes. I'm from the border triangle, Netherlands, Germany, Belgium, and I'm representing the foundations EU Prevent and APEX, which are located in the Netherlands.
Hello, my name is Renata Ilieva. I'm from Bulgaria. My organization is Bulgarian Association for Patients Defense, and I'm responsible for international and projects as a coordinator.
Hello, I'm Jasna Karacic-Zanetti from Croatia originally, but I'm covering 3 countries, including Belgium and Italy, and I'm head of Health Diplomacy Unit.
Hello, my name is Marta Kulpa. I'm project coordinator in Institute for Patient Rights and Health Education in Poland.
Gertrude Buttigieg, chairperson of the Malta Health Network, which is organization which brings together health-related organizations in Malta. Obviously, I'm from Malta.
My name is Manuel Ariano from Spain, from the Platform for the Patient Organization. It's an umbrella from several organizations in Spain who treat chronic people with chronic kidney diseases, defense of their rights.
Hello to everyone. My name is Alen Novit. I'm coming from Slovenia, from the Ultra Pceljes Society, which is dealing also with the patient rights issues.
Hello, everyone. My name is Kinga Vitovic. I am Director of EU Healthcare at RPP Group. To sure everyone hears me well. RPP Group is a public affairs agency, and we have our expertise lies only in healthcare. We'll tell you more throughout our presentation, but we work with policymakers for various organizations, having various projects run in parallel. And today we are here just to tell you more about why it's important to connect with policymakers and why they're hearing and waiting for your input. I'm based in Brussels, but I'm originally from Poland, so from the same country as Marta. Thank you.
Hello, everyone. I'm Luca Comincioli from Italy, and I'm a colleague of Kinga. I work at RPP as a consultant and support Kinga and organization, patents and medical organization in public affairs. Thanks.
Thank you. So please online present yourself. Dragoslav, do you want to?
Yeah, thank you very much, Dragoslav Popovic. I'm connecting with you from Belgrade, Serbia, and I'm representing Global Task Force for Immunization of the World Association of Public Health Associations.
Hello, my name is Paula from Portugal, and I represent the Observatory of People's Health.
Thank you. Alia?
Hear me?
Yes, thanks.
Good afternoon to everyone. Very much welcome the audience and people invited around and participating online. My name is Alia Kazbaeva. I'm a technical officer from WHO European Regional Office from the Unit of Healthcare Service Delivery. Thank you.
Thanks. Maria Teresa?
Hello, I'm from Portugal. I represent the Portuguese Society for Health Literacy.
Thank you. Georgios?
Hello, my name is Yorios Andrakis, and I work with Luca and Kinga. Thank you very much, everyone, for this interesting discussion.
Thank you. Irene?
Hello, good afternoon to everybody. I'm Irene from Malta, and I am the president of National Patients Organization, Malta, of course. We work a lot on patients' rights and as well as patients' charter. Thank you.
Thank you very much, Irene. So who's missing? Yes. Lyudmila?
Good afternoon. My name is Ludmila Mosina. I work for WHO Regional Office for Europe, which is based in Copenhagen, Denmark. And I'm a technical officer on new vaccines. Thank you very much for this opportunity to participate in this meeting.
Thank you very much. So now I give the floor to Mariano Botta for a brief introduction. Thanks.
Thank you, Bianca. Good afternoon and welcome to all. It's always a pleasure and a great opportunity to meet representative and leader of civil society organization, patient advocacy groups working at local and national level to protect the patient's right. I hope all you attending here in Brussels had a pleasant trip and that you connected remotely are also well. Thank you all for joining us. As Bianca already mentioned, today's meeting will be totally dedicated to COVID as part of the activities carried out within the European project empowering and mobilizing patient advocacy groups on COVID-19 prevention and treatment for vulnerable target group realized by my organization, Cittadinanza Attiva, Active Citizenship Network, founded by Pfizer, whom I thank for the support. I would also like to take this opportunity to thank today's three media partners, Health Europe, Trend Sanità, Policy and Procurement in Healthcare, and the Journal of Medical and Clinical Case Report, an international peer-reviewed journal published by Medivix Publication. In this last period, we can say since September, on the one hand, we have heard about a new study that tried to give some answers regarding the origin of COVID. The expert emphasized the importance of understanding the origins of the COVID pandemic, especially as it is concerned national security, also a public health. On the other hand, we are the expert concerned about the new variant labeled as more contagious than the previous ones, that the virus will continue to mutate and it has become something to live with, that COVID is still a life-threatening risk for fragile population, for at-risk individuals, but also that the new vaccine protect, so that the protection offered by vaccination remain crucial. Following this recommendation of the health authorities in each country were published. In my country, in Italy, for example, last 17th of September, the Ministry of Health issued a COVID recommendation for the autumn season and for vaccination with a precise list of the groups of people to whom booster vaccination with the new vaccine is recommended. Certainly useful indication. It is a pity that they are not directly addressed to the population and that in many cases not enough is done to reach the fragile population. In my opinion, the decline in COVID-19 testing worldwide has reduced the focus on public health measures to reduce infections among vulnerable population at higher risk of serious outcomes and long-term complications. With the lack of current guidance and misinformation on prevention, vaccination, on treatment, COVID-19 continues to have a pervasive impact on high-risk communities. We are also here probably to emphasize that despite the end of the public health emergency of international concern, COVID-19 remains an ongoing public health threat. Worldwide, thousands of people continue to be infected with COVID every week, exposing vulnerable population to an increased risk of serious illness, death, or ongoing consequences of infection. COVID-19 poses an ongoing threat to health system stability at a critical time of reconstruction, particularly during the autumn winter season, that when it co-circulates with other respiratory diseases, such as influenza and pneumonia. To raise awareness and inform policymakers addressing health inequalities, this is critical. It is crucial to understand how COVID-19 continues to affect daily lives, including the mental well-being of medically vulnerable population and their careers in the post-pandemic era. Thanks to independent experts from the WHO European Regional Office and our new partner, the World Federation of Public Health Association, what I would like to thank in advance, a common set of up-to-date information will be provided today. After the coffee break, we will get to know the COVID Community Council and then focus on how to ensure that our voice is heard by the new European institutions. In this regard, we have invited a public affairs consultant and a communication agency to help us. We invite you, as always, to make the most of this opportunity by interacting and not hesitating to ask questions. We need to feel comfortable this afternoon, and if you have any special needs, please do not hesitate to let us know. We look forward to learning more because, again, being well-informed and up-to-date is often the best prerequisite for promoting greater activism. Thank you again for your participation. I wish you a fruitful event. Thanks.
Thank you, Mariano. So we can start the first session dedicated to the vaccine-preventable respiratory diseases with a focus on COVID-19. And so I give the floor to Dragoslav Popovic, who is the member of the WFPHA Global Immunization Task Force. Dragoslav, if you want, you can share your screen. Thank you.
Yeah, I hope you can all see the screen. Let me just put it in a slide. Okay.
Yes, we can. Thanks.
Good. Thank you very much for this opportunity, and very happy to be today with you and colleagues from WHO. I think our primary focus is on public health. There is no public health without a great engagement of a society, particularly civil society and the patients' organizations, I would say, at the forefront of that. And I'll just go quickly through the reminder on pandemics and what we, in a way, gone through over the past couple of years to help set the stage. And you have nicely pointed out what are the current challenges with the COVID. But if we go back and starting with the pandemics, that's an epidemic that spread over a wide geographical area, affecting high proportion of the world's population, having a high prevalence of disease, and it lasts over the course of several months. With COVID, we know that we have a pandemic situation already since 2019. So we have several years of this wave of the pandemic. Pandemics are there as long as human population. It decimated world's population for centuries in the past. We need to remember the plague, smallpox, and then more recently Spanish flu, then HIV, avian flu, SARS, Mpox, COVID, of course. And the question is not whether it will be the next pandemics, but when this pandemic will occur. SARS-CoV, as some of you has already pointed out, is a novel respiratory virus. And I think the importance of understanding novel for several reasons. First, we were facing a virus that is new, that probably originated from the animal world and got the properties to help transmission from human to human. Whatever the origins of the virus are, and I'm very also interested, as some of you has pointed out, what's the origin, just for the sake of improving the laboratory and laboratory containment conditions in all countries. But regardless of when the virus is originating, we had to fight with it. And that fight was quite different from the beginning, when this virus was novel with very high transmission rate with very little knowledge and a memory about the virus in our immune system. So we were definitely not ready for that. The fatality rate among infected people were very high, and you would know that the first stage of the pandemics was marked by severely ill patients, out of which most of whom were requiring a very high level of different support, including respiratory support and life support to fight with the virus. Mortality was very high. Fortunately, as you mentioned in the introductory note, the virus mutated into new forms that are producing a very different symptoms in infected population, but still presenting a major public threat. From the beginning, with such a virus, we had very limited general prevention measures against respiratory viruses, and you would all remember that we had a very different kind of experience with the distancing, with the lockdowns, with the personal hygiene, with the personal protective mask, with the quarantining. And all of these public health and preventive measures were very much dependent on public trust in a government, and collaboration with the whole society. Therefore, the experience with those measures were very across the different borders and across the different regions of the world. In parts of in Southeast Europe, where I'm based now, we had much lower trust in the government, and despite the fact that we had that we were in Serbia, one of the first country that, for example, provided vaccines to a wide population, we were having very little coverage because simply lack of public trust. And this is where the public health associations, patient associations, and civil society organizations could have played a much stronger role, and maybe the outcome would be different. Initial response to pandemics, I think one of the lessons that we were having is that we had a very uneven impact on different population groups. You would remember that in a number of countries, elderly, senior citizens over 60 or 65 were those who were really under the most stringent measures in terms of lockdowns, very limited contacts with the family members, with the other members of a society. We had also a situation in which in the first stage of a pandemics, our knowledge about particularly children and young population and the COVID was very limited. So we had in some countries school closures that affected children population. In other countries, they were very different measures. Totally over 701 million confirmed cases globally of COVID-19, 7 million deaths, 2 million of those only in WHO Euro region. This is a very recent data, but we will see later that in some countries, excess deaths and excess mortality due to COVID was much higher than it was officially reported. As somebody pointed out, there was a huge strain on the health system. This strain was, I would say, a complex. At some stage, the COVID was affecting the access to healthcare, but also to other healthcare services. So the physical access, or the doctors who would normally deal with the other patients, with the chronic patients, or with the children, would be transferred to the COVID units and would not be able to provide timely services to those in needs. We ended up this pandemic stage with a huge backlog of the patients and huge waiting lists in a number of countries for different different health conditions. The health workforce was particularly affected for a number of reasons, including the long working hours, working in a very difficult conditions, under the stress, under the heavy personal protective equipment, and what was extremely important and very visible, unfortunately, in the COVID response, their mental health was under the huge strain, and many health workers, and there are several studies who were assessing that many health workers still having mental health problems. They need support to keep their mental health. Many of them were even having symptoms of the PTSD after working in the emergency unit or COVID hospital. What was also enormous challenge is the effort that was unprecedented in setting up global virus surveillance system, to set up mechanism to identify the virus, to follow the virus throughout the globe, to understand how one substrain is changing another one, and be able to alert all other members in this surveillance network about what is really going on in a real time, but also have a huge number of data that were helping to design effective policies and effective response to the challenge of COVID-19. When it comes to vaccination, I think that this is one of the success stories, I have to say. Since the beginning of a COVID, it started the race for the vaccine, the race to develop vaccine, race to produce sufficient amount of doses, and also race to provide, to procure and to provide those vaccines to the each and every corner of the world. And you would remember that 1 year into pandemics, we were having first vaccines developed against the original Wuhan strain. Later on, we got the vaccines against other substrains that were used as a booster. And as some of you has pointed out, as COVID is now moving into the stage of a disease that we will be living with for ages, we are looking now to continue protection by vaccination. We are looking for the new vaccines that would be relevant for the situation today and will be able to protect most vulnerable population group. The vaccine market, when it comes to COVID vaccination, also expanded exponentially. I have to say that COVID vaccination was probably the biggest, or for sure, the biggest vaccination event in the history, with over 30 billion doses of vaccines produced, procured, distributed, and administered to 67% of a global population. They were vaccinated with the primary series and 32% with at least one of the boosters. That's extremely high number, knowing that, for example, in the situation of avian flu 2005, 2006, I think, the global market was able to offer only 800 million doses of the flu vaccines in a situation of the pandemic outbreak. This success is has several, I would say, important factors and the players. CEPI as a coalition for as a new coalition established to help development of a new vaccines, and the COVAX Gavi UN mechanism to help governments from the middle income and low income countries to purchase vaccines on time. Unfortunately, we were also seeing some other events or let's say behaviors, some country which we put under this title of vaccine nationalism. Some countries were keeping vaccines only for themselves, and they were not exporting them until their own population was not fully covered. The other countries, talking about some very wealthy countries, were buying everything what was available, and there were some of the vaccine wastage, and that certainly behavior that we would like to change in the future with the more solidarity and more coordination among the partners. And finally, I would take this opportunity to repeat the something which all of you knows, but it's also so true. The vaccines are not saving population; it's a vaccination that is saving lives. And vaccination is not possible without collaboration of the health authorities, civil society, and all sectors of the society, including non-governmental organizations, associations, and even religious organizations. Sorry. Finally, apologize. What Mr. Tedros mentioned in one of his speeches is that infodemics that follow this pandemic is equally complex to respond to as our response to the virus. This is something which stays, and this is something which obviously affects not only delivery of public health interventions, but also trust of the population in some of the key interventions and some of the recommendations of a government. And this is something for us to think about how we can also tackle that issue in the future, particularly as we enter in the stage where the fake news and other modern means of communication very often do more harm than good when it comes to providing the right information about vaccination. When we think about legacy of the pandemic, COVID-19 pandemics, we have to also bear in mind that the end of pandemic stage, which was declared in May 2023, was not the end of pandemics. We see COVID circulating widely among the global population. My colleagues from WHO will talk about long COVID as one of the huge challenges for the medical and the public health community. And I mentioned in the past that many countries are coming up now with the data about excess mortality and morbidity, and we will probably need at some point to reassess the official figures that I presented in the beginning, because in some countries, including my own countries, the excess mortality exceeded the number of deaths due to COVID reported to WHO, and could be more than 2.5 times higher than it is. COVID pandemics left a huge impact on the mental health of population, on the functioning of a public health, and I, as a long-time UNICEF person, I have to highlight that childhood vaccination was probably one of the victims of the COVID-19, as we had enormous drop in the coverage during 2020 and 2021. We are now trying to recover what was achieved before, but we also facing with a number of outbreaks of childhood diseases. And as you know, enormous disruption in global travel, in trade, economy, and education. And all of this is asking for a much better and different kind of response and collaboration, much more global and local solidarity. WHO is working with the key partners, including EU and the civil society organization, on the new pandemic treaty that would help us to deal with the new pandemic in a different way. I would stop here. Sorry for this, but I would stop here. And if there are some questions, if we have time, I will stay with you and will listen to my colleagues from WHO with a great interest. Thank you very much for this.
Thank you very much, Dragoslav. Yes, if someone has questions, please keep them for the end of the session. And so I would like now to introduce our next speaker, who's Ludmila Mosina from the WHO Regional Office for Europe. Thank you. The floor is yours.
Thank you very much again for this opportunity. I am afraid I cannot share my slides.
Yes.
I'm not allowed, if it's possible.
Dragoslav, please, if you can end sharing your screen. Yes.
Thank you.
Okay, thanks.
I hope you can see my slides now on full screen.
Yes, we can.
Thank you. And I will give a very brief overview of global and regional COVID-19 vaccination policies and WHO recommendations on vaccination policies. And I'm really lucky because just a few weeks ago, the WHO Strategic Advisory Group of Experts on Immunization had its meeting, and they discussed updated recommendations on COVID-19 vaccines, and they provided a lot of updated information about the vaccine efficacy and the use of vaccine and national vaccination policies, which I'm going to use in my presentation. As it's already been told today, after almost 4 years since the onset of COVID-19 pandemic, the global landscape changed dramatically. And it's happened because of this widespread immunity, which was induced by vaccination, unprecedented vaccination campaign, and also by previous infection. And you can see that both mortality and morbidity due to COVID-19 significantly decreased, and also the severity of disease. It was also because the Omicron variant and its subsequent sublineages that are continued to circulate, they cause diseases at a lower rate, more mild diseases, less hospitalizations, and also a decline in post-COVID conditions. And you can see on this slide the trends in the severity of disease, in number of cases, in number of deaths, in number of hospitalization on the upper slide, and also including hospitalization into intensive care units, which also significantly declined. And as Dragan already mentioned, in May 2023, our Director General, based on the advice given by our International Health Regulation Emergency Committee on the COVID-19 pandemic, determined that COVID-19 is not longer constitutes a public health emergency of international concern. Although WHO declared the end of emergency, the SARS-CoV-2 virus continues circulating, and the deaths due to COVID are still reported. And at this next slide, you can see the reports that we received from countries in 2024 about number of deaths. And on the left part, on the left table, you can see the death by WHO regional, and totally it was reported more than 41,000 deaths. And on the right table, you can see the age distribution of these deaths. And based on reports from 41 countries that provide this data to WHO, around 88% of all deaths are among people who aged 65 years and older. WHO currently is tracking two variants of interest, which is JN1 and BA286. And JN1 is continue to be the most reported variant, and currently around 140 countries report circulation of this variant. However, circulation of both these variants of interest now have declining trends, and JN1 is accountable around 60% of all sequences in week 37 of 2024. The WHO also tracking 8 variants under monitoring, and 2 of them is KP311 and XEC, is showing increasing prevalence, and mostly it's KP311, and it accounts for around 46% of all sequences in week 37, and all other variants are decreasing. Dragan already told about the unprecedented vaccination campaign that's been implemented globally since COVID-19 vaccines became available. And currently we have several vaccines that are licensed and available on market, and several of them being adopted to target the latest Omicron variant, including JN1 and KP2 subvariants. And at this slide, you can see information about the vaccines products that have been reported by countries to WHO. And you can see that while viral vectored vaccines are being phased out, the mRNA vaccines and protein-based vaccines are in high demand. On the left side, you can see the information about vaccines that are used in countries by their income. Dark blue, it's high income, light blue, lower income, and upper middle income countries, blue and orange is low and lower middle income countries, and yellow is upper middle income countries. And on the right part of the slide, you can see the distribution of vaccine products depending on WHO region. And it is clear that the vaccines that are adopted to most recent variants are mainly available in high-income countries, and there is a lack of access to such vaccines in lower and middle-income countries. WHO, in collaboration with partners, implement ongoing literature review to monitor effectiveness of vaccines against circulating variants. And on this plot, I would like to present you this summary of data on effectiveness of booster dose vaccine against Omicron latest subvariants. And to understand this plot, each line with the information on the left part of the slide represents a study with a short information about the country where it was conducted, about the subvariants that was circulating, or variants that were circulating when study was conducted, what was the age group, sample size, and so on. The colored marks and horizontal lines present the results of the study, and you can see the proportion of vaccine effectiveness below. The mark, it's a point estimate. The line, it's a 95% confidence interval. And the colors indicate, you can see on the legends on the right, the vaccine that actually been in use when study was conducted. And you can see that on the top part of the plot, the vaccine effectiveness against death, in the middle against severe disease, and below against any symptomatic disease and infection. The study populations mainly are mixed, but mainly elderly in all the studies that have been conducted, and also immunocompetent adults starting from the age of 18 years. And the protection against GN1 variant death caused by GN1 variant is quite high. It's between 50 and 75%. And the protection against severe disease ranges from 30 to 70% in different studies, whereas protection against symptomatic diseases and infection is lower. If we summarize, I show you only one plot for GN1, but we also have monitor the vaccine effectiveness against other variants. And if we summarize all these studies, we can see that vaccine effectiveness against severe diseases caused by the Omicron subvariants remains substantial and relatively stable over time. There's some studies looked at duration of protection, and for against diseases caused by GN1, the duration lasted up to 4 months. But it's again, we should keep in mind that the main study population were elderly. The protection against symptomatic disease and infection are lower than against severe disease. And if we compare the vaccine effectiveness against mild disease and infection currently with their effectiveness against pre-Omicron variants of concern, we notice that it wanes more quickly after the last vaccination and in general is lower. The vaccine demand in 2024 has significantly dropped. And you can see that on this bar and on the very right part, there is an increased version of information for 2024. And you can the color indicate the WHO region, and mainly vaccinations are given in or reported from countries from Americas or Europe. And we know that many middle-income countries and lower middle-income countries report very, very low coverage currently with the uptake of vaccines, booster doses in most vulnerable population, less than 1%, and it's really concerning. 73 countries reported to WHO about their vaccination policies, and 57 of them reported that they recommend periodic vaccination for at least one population group. And you can see this population group that are prioritized by the countries. It's older adults, adults with chronic conditions, older adults with chronic conditions, healthcare workers, pregnant women, children and adolescents with chronic condition, and in less amount of countries are children and adolescents, adults, and other groups. At its recent meeting, the Strategic Advisory Group of Experts on Immunization reaffirmed its previous recommendations on priority groups to be vaccinated against COVID in the context of Omicron and substantial population immunity. This roadmap was developed in 2023 and was last updated in November 2023. WHO defined a few high priority use groups, such as oldest adults, and each country decide what should be a threshold, and it's usually around 75, 80 years old. Older adults with multiple comorbidities, and older adults defined as those who are 50 or 60 years old and older, and also other adults with severe obesity or comorbidity. WHO also defines subpopulation with special considerations, which also considered to be high priority use groups. It's like people who have moderate and severe immunocompromising conditions, pregnant adults and adolescents, and also health and care workers who have direct contact with patients. And two other groups which WHO defined medium priority use and low priority use, it's mainly include healthy adults, healthy children and adolescents, and those children and adolescents who have severe obesity or comorbidities are included in medium priority groups. And Strategic Advisory Group of Experts developed recommendations on vaccination for each of these groups. And for high priority use groups, WHO recommends that booster dose should be given with interval approximately 12 months. And for those who are oldest adults or older adults with multiple comorbidities, this interval can be shortened up to 6 months. For the person who has never received COVID-19 vaccines, for the programmatic reasons and point of view, the single dose that will be given to them for the first time would be considered as vaccination. For the subpopulation with special consideration, their recommendations vary. people with immunocompromised conditions who have never received COVID-19 vaccines should receive primary series of vaccination, 2 or 3 doses, and in consultation with their health providers. And these doses should be given with interval between 6 and 12 months. And again, the interval should be discussed with their healthcare providers and will depend on periods where they receive or don't receive treatment. Pregnant people should receive a single dose during each pregnancy, regardless of previous vaccination status, ideally during the 2nd trimester or at any opportunity when there is a contact with a healthcare provider. And health and care workers who have direct contact with patients should also receive a booster dose every 12 months after previous dose. For the lower priority use groups, like medium priority or low priority, vaccination not routinely recommended if there is a vaccine-naive person. Medium priority use groups can receive a single dose. But with regards to healthy children and adolescents, WHO does not recommend vaccination, but countries could consider vaccination based on their local context. And WHO again emphasize kind of acknowledge the decrease in vaccine demand and vaccine uptake, but emphasizes the importance of booster doses or revaccination of high priority use groups, the most vulnerable people who are at high risk of developing severe disease or death if they are infected. And WHO also recommends that in countries where it's epidemiologically appropriate, because we still did not define seasonality for COVID-19, but where it's epidemiologically appropriate and where it's programmatically feasible to co-administer COVID-19 vaccine with the seasonal influenza vaccine. Thank you very much. That's all my slides. So if there will be some question, I will try to answer them. Thank you.
Thank you very much. So now I would like to give the floor to Alia Kozbayeva, who also represents the WHO regional office for Europe. So yes, the floor is yours. Thank you.
Thank you so much. It's my video. Now I will try to share my presentation. Yeah. Okay. Can you see it in a presentation mode?
Yes, we can. Thanks.
Okay. Thank you so much. So first of all, thank you so much for inviting to participate, and nice meeting with Dragoslav and Ludmila with this occasion, and very interesting group and the participation.
Alia, sorry.
Yeah.
Could you please put it the full screen?
Yeah, let me. Where is that? I think I am.
Is
Let me.
At the bottom of your screen on the right.
Yeah. I think
yeah, that one.
Yeah.
Thank you.
Sorry. Yeah. Because
Perfect.
I'm dealing with a small, tiny screen now. Okay. So I was asked to touch base on the publication that was released this year in April. And I think the preluding presentation very well put a framework for the overall COVID vaccine preventable conditions and overall situation with the COVID. Thank you so much to colleagues. And mainly, what we were like, and Bianca, you were mentioning before that what we are talking about when we speak about long COVID or post-COVID condition. And this is also a very unique situation when COVID was very rapidly developing. And again, with the very active participation of media, journalists, and public, the whole process was developing far faster than in usual condition, as we were witnessing like 20 years ago with the avian flu or swine flu or other events. Therefore, the engagement of the general population was very much represented here, and that has its pros and cons, and we have already highlighted that, and this infodemic as well, and also accelerating and triggering operations not only from the governments but also from the population affected, first of all, to move the agenda and policy agenda forward. So basically what WHO did is first of all to identify clinical definition and case definition. And that methodology was exactly being developed with participation of researchers, experts, but also very much of those who were indirectly affected by patients as well. And that's very unique in this regard. And the body of knowledge was rapidly developing over this period of time. And by March 2023, a new clinical case definition for post-COVID condition in children was identified, because they have a slightly different clinical duration and manifestation. And this is in the frame, it's basically the definition that being developed by Delphi method. And that's being said, so it's unprecedentedly kind of fast development that was agreed and published and became available to all member states. Yet there are also kind of different approaches and different definition being used as well. As I said, like in UK, in Italy, and many other European countries, this term used as long COVID. And that also possesses some kind of challenges to trace in the countries what we mean. And especially, as we mentioned before, that with the kind of, as of May last year, when the global emergency has been kind of lifted, the attention of the countries and probably priorities in public agenda and health agenda has been also being forced to be away a bit from COVID and long COVID, and fatigue as well of the policymakers, financial fatigue and other aspects. So, but WHO still tries to identify that this is a global problem, that we still need to identify what actually is long COVID or post-COVID condition. And this is a complex and new and not well researched, although body of knowledge is rapidly growing. And it's also very complex, and that requires that it's applies a multiple way to approach and understand epidemiology. And what Ludmila was mentioning, that as we clearly understand that vaccines are helping, vaccinations are preventing, and the trend and attention, availability, access to those vaccines are, we just saw that getting less and less and less. But with the people who are suffering from also long COVID or post-COVID condition is still kind of high, but how high, that's a big question here, because the registration of those cases are very limited. Those people are suffering with stigma and understanding and social kind of aspects to that. And this is the statement which was done last year. And what we know that it's definitely, we still need to approach and understand what is the basic burden of post-COVID condition. And there are many countries in EU, particularly, they are trying to revise the definition and the approaches, and to be kind of more strategic to understand what, how Italy can be applied to other countries as example. And also to advance public awareness and combat the stigma. That's basically saying, so it's still one of the factor of when initially this classification, what is the recognition, how to code that condition in ICD, International Classification of Diseases, it's there. but what and how is registered, because the diagnosis of COVID even not systematized now currently. Not many people go, if it's mild form, they don't go, but the consequences can be even with the mild form of COVID or non-clinical form. And that possesses a huge challenge, what we are facing with. And that requires a global research. And because people are suffering, and already, Dragoslav, you mentioned that many children who were like lacking school, and there are many publications now available in English, especially based in UK examples. Those children who were missing school classes, they are now developing cognitive retardation, I would say, that they are not able to concentrate and others. So that's a big societal issue that we still far from understanding the scope of it. And one of these attempts to keep up the attention was the publication of WHO and Call for Action in 2022 before the regional committee, which was held. And this is about what are the integrated models to manage post-COVID condition. And this mainly discusses, and that's the key messages of that is, first of all, the actions are needed from member states, from research, from politicians, from all relevant agencies. And that's basically mainly to be able to early identify and recognize symptoms of post-COVID condition. Also to acknowledge the need for individualized long-term rehab care for persons with PCC. And that's, as primary health care is one of the front line who is facing with the patients or those who are suffering, to be well equipped to deal with that condition. And also to understand how the multidisciplinary pathways are expected and to be needed for those patients. This was also a side event during the regional committee session in September 2022, and that's the major items that were highlighted. And also with the engagement of the patients, is basically, first of all, involve patients, healthcare providers, and scientists. Also trying to standardize data collection and clinical trials, promote research and pool resources, share good practices, and also improving integration and planning of the services. That's why in 2023, WHO decided to assess what are the models of care for people with post-COVID condition in selected countries. And the attempt was to try to collect available information in selected countries, because it's also a question how you assess. And this is, some countries are much well represented in the literature available, some are the less. It's also due to income country groups and the capacity to invest in certain research. And that's another kind of drawback, I would say, in some lesser known country or less resourced countries. That's a bigger challenge. So we try to assess respondents primary from like Ministry of Health, national public health authorities, practitioners responsible for service delivery, and understand what funding is available for this and how this planning can be improved to manage those patients. These are basically major areas and categories we try to assess. And I slightly kind of touched base on the first kind of what is the condition, how the country identify this condition, because as I said, the WHO definition is there, but each country has its own kind of way to identify and define that and register that. Also prevalence estimate and how patients are managed, and how services are organized around that, and the patient pathways. And whether health information system is sensitive enough to see that and to be able to track those. And also, as again, we were tackling before that, foremost, the healthcare workers were affected the most during this COVID conditions and the difficulty conditions and extended shifts and other aspects that they had a lot of effect on healthcare workforce, first of all. So, and that's what are the available funding, because during, and this is another kind of thing, during emergency situation, country try to mobilize all resources that country has. And since the emergency is kind of lifted, the country are, even if they, or the ministries of health, even if they want to keep some services, they have much limited opportunity to keep up the services that were set up during emergency phase. And that's kind of another kind of condition or environment that we have to deal and then to address it in a certain way. So, and that's also what are the communication strategies, community participations, and also challenges and other aspects. So basically, we ended up to be able to work with the 5, I would say, countries, and that was Israel. And this is how, and Israel is also kind of, which is part of our region, and in Euro is the budget or like a social system that is existing. So that's how, in a nutshell, the person is facing the services, and that's basically how it's organized. And they have services that every person in the country being registered, so it's quite easier to follow up the population move, and that's one of the kind of compact system that gives a lot of information and pretty well documented. And this is how the primary healthcare facilities are being in charge, and how the services can be organized at the hospital or primary health care, and how the integration can be done. Also for Italy, because Italy was the first hit country, and understanding the demography of that country, and a lot of funding were allocated by the country and by the European Commission in general. And also people were a lot admitted to the hospital, and those who has this a different level of interaction by healthcare system. And this is basically how that it was organized. And in UK, it's also, again, one of the first countries who developed this kind of big guidelines, and many countries were using that. And this is quite complex, but also by timeline is also kind of a bit, so there are some different examples, particularities, giving hints how the country were developing that or allocating additional funding, and the UK was one of those, having a lot of specialized clinics who were dealing with the long COVID conditions, which also now have much less opportunity to keep up with this. And also, as a part of Spain, Catalonia has also this certain pathway how to deal with at the primary healthcare level, and what are the conditions and what the conditions they were monitoring. And that also referred to the secondary care level, what are the conditions and how things are followed up. And this is the report and the link to that. And basically what is the major finding is high prevalence, but going deeper and more granular data is very difficult to assess. And as I mentioned already, gap of conformity tests, because the situation, more and more people having COVID as a flu condition, they don't even go to healthcare facilities. If they do test, they might do that at home, and that it's not registered. And maybe if some conditions are developing 2-3 months later, that's also a big question, how it can be attributable to COVID or long COVID condition or post-COVID condition. Therefore, surveillance were, when we started this kind of work, it was still emergency condition, and surveillance are still evolving with a certain limitation. And as again, is a blueprint that PHC is often the first point of contact. As in many countries, they develop multidisciplinary teams because people are suffering from long COVID or post-COVID condition. They have such a variety of manifestations, from neurological, from just fatigue, gastrointestinal manifestation, brain fog, cardiovascular conditions. So that's why it's not possible that one group of specialists can deal with that. And that's how basically the services can be integrated, well coordinated to refer to each of the required facilities, and as well of rehabilitation services for those most affected. And that's basically, again, as I mentioned, challenges in funding and resources. Since global emergency has been lifted, that's possess a big challenge. And we are facing now in each country very much of other kind of conditions that we discussing every day. And that's said the role of patients getting more and more important to be engaged and defend their rights and to keep the agenda running. And that's basically bring us to the conclusions. Still, we need to do advocacy, education about the condition. We need to allocate funding and also to train healthcare professionals. Still keep conducting research and preaching for the better data to be collected and be available. And support scale-up services based on the examples or documentation of some countries with the pros and cons and results achieved. Integration is one of the key aspects, again, to the complexity of the condition. And also the rehabilitation possibility to the patients, or not patients, people are suffering. And again, as I said, education specialists, teachers, healthcare workers are also among the most affected and that's the problem. We are trying now to set up a research and survey, but the problem methodologically is, and I didn't focus here, we are about to publish another about rehabilitation healthcare workers affected by long COVID, also in other 5 countries. But the problem was that even online questionnaire, when you finish it and design it, people who are actually suffering from long COVID or post-COVID condition, they have no possibility kind of concentrate still. They are getting better. The statistically, maybe the duration is now 4 years, but for them, it's very serious condition. They can't focus at times, and it's also occupational because they have to change their job because they cannot carry on working in intensive care unit or rehabilitation or social service. And that's also a mental health support to be provided for these people. So, and this is basically in a summary. I won't repeat it again. And the last slide, this is resources for post-COVID condition. These are clinical management with different chapters, and this is live document. This series of post-COVID condition available in several languages, including Italian. And there are website where we have some dedicated publications on that. And this is rehab resources, as I mentioned, some in different languages, including Italian, just for your interest. So, and that's basically main aspects. Thank you so much.
Thank you very much, Alia. So are there any questions both in the room and online? Yeah, sure. Please go ahead.
Thank you very much. Thank you very much to both presenters to give the professionals insight into the realities of what happened with COVID. I just have 1 or 2 quick comments for Dr. Popokovic. My apologies. When he was talking about the impact of COVID, some analysis our organization did during COVID was the actual impact on our acute hospital system. For example, we found that something like screening fell by 55%, and that's screening for breast cancer, cervical cancer, excuse me, bowel, and diabetic retina. That amounted to 400,000 people in that 12-month period. Also, that the impact on admissions to our hospitals was the equivalent of almost 6 weeks of normal admissions. So that was, in other words, 13% of our normal admissions for other chronic issues, not just related to COVID. And also ED attendances were down by something in the region of about 8 weeks. In other words, the number of people that would call, in the normal day-to-day activity. So There are figures that I haven't actually seen, collected to actually illustrate the impact on, how would I say, the other illnesses other than COVID during COVID. And if I take your comments there from what you were saying, I think the challenge is that long COVID and the effects of COVID is really a new chronic illness that's been identified, being all put on top of all of the other chronic illnesses that we're trying to deal with, which the management of is not quite sewn up anyway. So we're trying to give a sewn up, a joined up version of dealing with long COVID on the systems that are still not really aligned for the needs of other people with chronic illnesses. And I think that is a really big challenge. And that is where I think in your recommendations, you're talking about having better IT, information that we can actually analyze the data relatively easy rather than having to do big studies. So thanks very much. I mean, that's certainly my little takeaway from the session is that we have a serious chronic illness. I know a number of people myself that are in that position, but what we're trying to do is graft it onto an already overburdened system. Thanks.
Yeah, but thank you very much. You're absolutely right. As Alia was saying, we are just collecting the information from other countries. I mentioned the childhood immunization. It drops globally for more than 20 percentage points. And somebody was saying that the COVID put us back into the pre-2000 situation, and almost annulled the major progress that we have made over the past 2 decades. I think the takeaway message, I totally agree with you. The message is simply, it's not over yet. And long COVID is enormous strain. And I have to say, just as an anecdotal information, but at some point 2 years back, I participated in one of the global meeting when we were discussing whether COVID is respiratory disease or not, because the effects of the infections and the virus on other systems like circulatory, for example, was enormous, and that created number of patients with the long COVID, number of people that now needs much more serious interventions, or people that would need rehabilitation, as colleagues from WHO pointed out. So in that sort of situation, I think number of health systems were not able to balance the support to new patients and those who were chronic with the chronic conditions from before COVID, and that continue and will continuing for many years. Therefore, I think the understanding of what Talia was saying, data about all of that is something that would probably shed totally different lights on some of the properties of the virus and the infectious, how we were seeing them in the beginning of the pandemics. And there is a lot of work for us to continue advocacy, again, not only for the group that is affected by COVID, but also for everyone else. And that's a mission, I don't want to say mission impossible, but it would be a very difficult mission because it really require scale up in terms of funding, human resources, and everything else that is necessary at this stage. But we need to understand how grave consequences of the COVID pandemics are. And thank you very much for that comment. And you're absolutely right. We need to have figures. We need to have a real burden quantified to be able to even more with the more competence to talk about these things. Thank you.
Thank you, Stephen. Thank you, Dragoslav. Any other questions? Yes, please, Gertrude.
On the clinical aspect, how is differential diagnosis being made from something being a standalone condition and the post-COVID, a long COVID, because this is very significant for the patient community, especially when they are interacting with their health professionals. How significant is it that they have been affected by COVID a year ago or 3 months ago or 5 years ago, and now they are exhibiting certain symptoms? I think there is a lot of learning which we need to do in order to sort of reduce the knowledge imbalance between what professionals are calling long COVID and the experiences of patients. I don't know if you have an answer for my question.
I guess the question comes to me. I would love to be able to respond to that question and maybe nominate it next year for Nobel Prize in public health. You just rightly mentioned that it's a very complex condition, and as we said, that what are the professionals are being trained for and how it's hidden the long COVID condition among other symptoms, as we just, Dragoslav, and before the question that people are still suffering from cardiovascular diseases, cancer diseases, and other, and what are the general professionals are alerted enough to diagnose that and put that and deal with that, moreover from diagnosing that. And this is a big question. And this is, and also there's a big consideration in the data for those people who were hospitalized, and for that we have much better figures, and those who were admitted to intensive care units, they are kind of also a little bit better because they were institutionalized, those patients, whether they've been identified with the COVID initial cause of further conditions, but there are still, it's like tip of the iceberg, those who were hospitalized, who were admitted to ICUs, but there are plenty of other people who were kind of having mild or kind of unnoticed conditions that suffering from long COVID, and that's still to be identified. And there are a lot of publications and research is ongoing, and WHO headquarters also still have the global expert group that are working on those definitions and identifying the plausibility of available evidence and identify some suggestions on that. I hope I have covered to some extent your question on that. The global community is still learning, and public health expertise is still growing on that, how to address the most efficient way in given resource setting, be it human or financial. Over from me.
Thank you. Thank you very much. So any other questions? Okay, if not, so please let me thank again our speakers for the first session, Dragoslav Popovic, Lyudmila Mozina, and Alia Kozbayeva. So we will have a small coffee break, and so we will meet again here in 15 minutes. Thank you. And thank you again.
Thank you again for the opportunity.
Thank you. Thank you very much. Wish you successful work, and we would like to hear some feedback from you.
Oh, yeah.
Looking forward to that.
Oh, yes, you will. Thank you.
Thank you.
Pleasure.
So, welcome back. And let me introduce you the speakers of this session. So connected online, we have Frank Angelo Spinelli from Pfizer. And then we have Kinga, wait, sorry. Sorry, from RPP. And then we have Joanna and Nita from the communication agency. So thank you very much. Frank, the floor is yours.
Can you see my slides?
Yes, we can.
Okay, great. Well, thank you to the meeting organizers for inviting me here to talk on behalf of Pfizer and the Global COVID Community Council. So for many of you, you already know that in May 2023, the World Health Organization declared that COVID-19 was no longer a global health emergency, marking the symbolic end of the pandemic for governments, healthcare institutions, and the wider population. Now, while this announcement was a cause for hope for many, COVID-19 continues to impact medically vulnerable people. For example, those who are living with HIV, some of those with cancer or solid organ transplant, who remain at heightened risk for severe outcomes and long-term complications. So despite the availability of vaccination programs, these medically vulnerable individuals remain at increased risk for hospitalization and mortality due to COVID-19. However, beyond the recommendations of mask wearing and routine vaccination, there has been a gap in global and national health guidelines in directives regarding testing, treatment, and protective measures that are tailor-made for medically vulnerable populations, their families, and their caregiver. And as a result, these individuals continue to live every day in fear of contracting COVID-19 from the start of the pandemic. And while the rest of the world has seemingly moved on, there needs to be practical day-to-day guidance, and general pandemic-related fatigue and lack of understanding and awareness of long COVID has left many of these medically vulnerable individuals feeling isolated, disempowered, and quite frankly, anxious. So to protect the for protection of the medically vulnerable populations, it is integral in the realization of global human rights and the promotion of health equity. And in the context of COVID-19, the importance of aligning global health initiatives with the UN Sustainable Development Goals, or SDG, notably SDG 3, has become increasingly apparent. And so to design policies that effectively safeguard and support and legitimize the unique challenges experienced by medically vulnerable groups, it is imperative to adopt a participatory approach that is community-driven and grounded in evidence-based, culturally appropriate, and context-specific solutions. So last year, Pfizer set forth an initiative to engage with community members from organizations around the globe and established the COVID Community Council, which represented 8 representatives from leading patient organizations from 6 different countries. And as you can see, here are those council members and their affiliated organizations. And what we set out to do was, this is the timeline, was that we wanted to organize this meeting to listen so that we could better understand the needs of these medically vulnerable patients and from their representatives. And we identified 7 barriers to COVID-19 testing, and then we did some pre-work. And then the first meeting was held virtually in October of last year, and we identified areas of impact also on mental well-being. And then we came away thinking about sort of solutions for supporting medically vulnerable individuals, both on a mental health well-being and also what are the barriers to testing. And then internally in Pfizer, we did pre-work and our literature review. And then we reorganized or reconvened the council to meet in December. And what we found that, well, based on the literature search, is that we really galvanized around certain themes and areas. And here, this is a thought bubble, and these are some of the emerging ideas that came. And as you can see, things that really bubble to the top are lack of guidelines, lack of trusted resources, but also you can see here a couple of mentions about confusion or failure to really define what long COVID is, how to better educate their patients and their members of these organizations, and looking for awareness and how to really establish a dialogue with their healthcare providers. And then 7 barriers to COVID-19 testing were identified, and these had a lot to do with cost of testing and isolation, testing not being made available or free in certain countries, test authorization and distribution, accessibility to testing, test variety and accuracy, a confusion about which test was more important or which one was more accurate, guidance for positive results. What do you do when you actually have a positive results? Where do you go? Education and awareness around the need of what to do next and on COVID vaccination and treatment options, and COVID fatigue. We hear a lot of what is well described globally on the HCP side, but we don't see it very well described on the patient side. And then the council also identified 5 areas of impact on COVID-19 on mental well-being and medically vulnerable groups and their caregivers. And I know it might be hard to see, but I'll just read these out. So impact on the individual themselves, impact on the individual's family, friends, and caregivers, impact on information dissemination, the surge of misinformation or disinformation or fake news that has really become predominant on, particularly on social media. And then impact on healthcare services. We heard a lot that just getting in to see their healthcare provider had become very difficult because of the way the COVID had really impacted their clinics. And then impact on society overall, just the lack of clear definition that led to dismissive attitudes and underestimation, and then also stigma for those who wear masks or who choose not to. So as a potential way of co-creating some solutions, the council suggested 3 potential solution areas. So the first was raising awareness of available treatments for COVID-19, communicating the availability of effective COVID-19 treatments would help alleviate the anxiety for many of these individuals. 2, widespread education. The council felt there was insufficient awareness of COVID-19 ongoing impact. A lot of the misinformation is like, the pandemic is over, therefore COVID is over, when in fact data, testimonies, and real life stories show otherwise. And then mental health impact and support for accessibility. So the accessibility of mental health resources to help improve quality of life and general well-being on a day-to-day basis. So after the second meeting that took place, there was really a desire for a call to action statement, which I will show you in a little bit. But then we wanted to reconvene the group this year. And so we performed another literature search to really identify what was the gap that we wanted to address. So the objectives of the literature review were to conduct a search for published literature around guidance of COVID-19 testing and treatment in medically vulnerable high-risk communities and the impact of COVID-19 on mental well-being, summarize any of these supportive guidance and research findings around mental well-being in international and community level, and identify potential programs and tools that address these barriers already. We did not want to reinvent the wheel, and certainly we wanted to find something that was missing or the gap that was more importantly or prescient. And then based on the council's critical appraisal of the tools that we highlighted, we selected tools and interventions that highlighted in the literature review, and the council members identified 5 beneficial elements for future COVID-19 solutions to inform the council's recommendation and support this call to action. And I won't read these all to you, but as you can see, it was really about engaging multiple stakeholders, use diverse communication strategies, adapt strategies from the vaccination program, which had worked so well, overcome educational gaps, and don't forget about the general population. So the Council's discussion also focused on key recommendations for the practical implementation of future COVID-19 intervention tools. And this related to these 8. So mental health toolkits, visual aids and simple user experience, wider public awareness, accessibility that's tailored for the diverse audience, some source reliability, influencer support, particularly on social media, more and more relying on the pharmacist's involvement, which is particularly important for certain countries, and then having multi-stakeholder involvement involving a range of stakeholders that include media and roundtables and other insights that we could really uncover these knowledge gaps. This is the call to action statement. I'm not going to read this, it's a lot, but really what was more important was that in the future, it is imperative that the public health policies and communications not only recognize and validate the experience of medically vulnerable groups, but also enhance the visibility and provide strong support mechanisms. So what is going to happen next? As I mentioned, we had the call to action statement. We thought, what could we do with the council to really co-create and identify gaps? And so the decision was made to possibly have a survey. So the council's call to action and accompanying recommendations established a robust platform for enhancing the accessibility within medically vulnerable communities. And by engaging with these representatives, we identified a gap, which was really looking at a survey that we could implement globally. So we wanted to discuss what would be the gap measures, and after the survey and after a literature review, we identified these areas or these domains. So timing, focusing on post-pandemic, so post-Omicron, looking at acute infection, but also looking ahead at long COVID or sustained symptoms after the acute infection. We wanted to focus on adults, but particularly those who are older, so let's say older than 65, having comorbid conditions or who are immunocompromised. Locations, we wanted to focus on the US, Europe, and Asia, and looking at quality of life, mental well-being, but also the other psychosocial impacts. Let's say, for example, the financial impact that COVID has had on people's lives or on their caregivers. And we wanted to root this in a methodology that was with the CAP framework, so knowledge, attitudes, and practice. And this would be an online survey. So how did we address these gaps? Well, these are the 4 objectives. We wanted to gain insights in the challenges faced by medically vulnerable people since the pandemic. So it didn't matter how many times they had COVID, they would be looking back to the last time they had COVID, which had to be January of 2022 or to the present. We wanted them to describe the physical, emotional, and psychosocial challenges associated with having COVID-19 and the impact on quality of life for these individuals. And then examine the role of shared decision-making between patients and healthcare providers in supporting medically vulnerable people to have a better experience with their healthcare. Much of what we do relies on what the HCP's beliefs are instead of what the patient's needs are. And so this would hopefully bridge that gap. And identify knowledge gaps through mapping out the perspectives, experiences, and challenges faced by medically vulnerable people within the context of current public health interventions, and then utilize these insights to better help inform programs and initiatives that are supported by Pfizer. So here is the methodology on one slide. So as I said, we're planning on recruiting 2,500 medically vulnerable people. They would have to self-identify as having COVID after January 2022 in 5 countries in Europe, Asia, and the US. We would be using an online platform resource and an agency so that this would be blinded. There would be no product names, no vaccination names, and it would be a very discrete questions that you could answer yes or no, or using a Likert scale. And the hope is that we will have this executed by the end of the year with readouts hopefully by first quarter of 2025. And that was it. And I hope you'll invite me back next year when I can give you more information. So if you have any questions, I'd be happy to answer them.
Thank you so much for the presentation. Any questions? But in the room and the line, yes.
Hi, Frank. Mariano speaking. Thanks
Hi.
a lot for your presentation. Thanks for the Community Council. That is an example in which we will have the chance to discuss about the pandemic, the burden of COVID, etc., without any borders, in terms that for us could be easier to be in touch with other association based in Europe, but it's extremely difficult for us, for instance, to interact with association based in Mexico, as in the border is the country represented. So this is extremely useful to exchange information, etc. Just for your information, here they are present in here in Brussels, but also connected representative from patient advocacy groups from apart from Italy, Ireland, the Netherlands, Austria, Bulgaria, Croatia, Poland, Malta, Spain, Slovenia, and connected also by in Portugal and Malta as well. So there is and
also Greece,
because there is also, thank you. So there is a great representation of our constituency. And together with them, we are interested to realize an on-time and online survey, not tailored directly to the citizens, that is quite difficult for us, but tailored to the leader of patient advocacy groups. Focus on impact on COVID, etc. So we can probably have the chance also to comment the result, what come from our survey, what will come from your survey. So thanks again, Frank. I don't know if someone else, please. Thank you.
Good afternoon, Dr. Spinelli, Steve McMahon, Irish Patient Association. Have you given any thought to how the implementation will be overseen from the various, issues that are identified with your survey? Or because that is a huge challenge insofar as that even within Europe, and I would think even within the States, that you have different speeds on the way things are done for different sort of populations of patients and economic backgrounds and so on. So I was just wondering, have you sort of built in, or are you planning to build in any sort of oversight to see the implementation of how it's carrying the next step onwards, if you get me,
Right. So, there has been a lot of thought about what to do with the results. And obviously, choosing 5 countries makes it very narrow in the beginning, although we do have a plan for a significant number of individuals. This would be descriptive on a global level. So that is one of the limitations. But I see the potential of doing regional views. So let's say, for example, the United States. It's a huge place. But what you really would highlight is identifying disparities, let's say, of living in New York versus the South versus the West Coast. And I believe you could do that as well, looking at the Asian countries or the European countries. I believe once we establish the results and describe them, and then hopefully get them published, we would be able to, on a country level, have the council members support the cascade of this information. But I also see a great deal of interest on the Pfizer end. And I can tell you now, there has been a great deal of enthusiasm of engaging with the community and organizations in this capacity. And there is already a plan for early next year to expand this so that we can then survey 10 countries with double the number of participants. So I think of this project as more like the pilot, and what we learn from this, we can then implement to a broader survey and maybe hone in a little bit more and see what we come up. But I do understand the challenges, but I think, this is a great starting point.
Thank you very much.
Thank you all.
Thanks. Any other questions? No. Okay. So let me introduce you, Kinga Wojtowicz from RPP group. Thank you.
Thank you very much. For the future, I can always go by Kinga. You know, Kinga is fine. Kinga is fine. The last name is not easy to pronounce. At the beginning, I would like to note, and I've aligned with the organizers, I would like to have this session more interactive, because I don't expect you staying focused for 30, 40, 45 minutes, me talking about EU politics, because I know that it's not the most exciting one to work in. There's a lot of theory, there's a lot of things that you have to know in order to use specific tools that you have for public affairs. A few words also of introduction. Why am I here, and how we've been collaborating with ACN for, I would say, well, more than a year for sure. But we've been working, Luca, and yours, my colleague who's with us online on the COVID project. We have been trying to collect from the national perspective different barriers, different challenges, what's working, what is not working, and try to keep this issue on the topic of the EU agenda, which was not easy. The second that the WHO announced the end of the pandemic, then it has been coming quite difficult because there are other topics that emerged: war in the Ukraine, different funds being trying to also be different funds being earmarked for other areas. So on top of that, policymakers also were tired. They're also humans, and they didn't want to hear about COVID anymore. So this is also a challenge that we are trying to move forward with, trying to tackle. But I know that it's not easy at the national level to keep this topic on the agenda because of the exact same reasons. But it's also not easy at the European level. But with our expertise and also the expertise of ACN, we are keep moving forward and trying to keep it on the agenda. Now, before I delve into this, I have an open question to everyone, because I know that you have been working at the national level, working with patients, but how many of your organizations are involved in working with policymakers? Shall it be the ministry or members of the parliament? Is it one of your key areas of work, or is it working with patients and for patients together, providing support? So how does it look like?
Okay, from Bulgarian Association for Patients' Defense, it's regulated by law that we should be part of some of the, for example, Commission for Health in the Parliament. We're also part of our council groups, which are operated by the Ministry of Health. So if you want to propose something and to discuss it with them, this is the easiest way. Also, we're part of the National Healthcare Insurance Fund, where we should discuss about the payments, because this is also very responsible and interesting point of view. So first of all, we collect with other patient organizations their opinion, what we should think about it. And after that, we represent it in front of the policies makers.
Wonderful. Thank you very much. And I know that in Bulgaria, it's not easy with this continuously changing government. How about other organizations? Yeah.
We work with at the regional level, at national level, and the European level.
The European level as well.
Yes, our director of the platform of the patient organization is member of the European Patient Forum.
Okay.
Also. So
Quite a very big organization.
I was member of the board of the European Patient Forum as well.
Okay.
So I think it's necessary, the collaboration between policymakers and patient association.
Any other organization that is actively involved in policymaking, working with policymakers?
Yeah, we also work with policymakers on a European level, but also on a regional level. And since we are also active in the border region, so we are cooperating with policymakers from all three countries, so Belgium, the Netherlands, and Germany. And then in Belgium, also from Wallonia, Flanders, but also the German-speaking community. So
even the Belgian-speaking community. Okay, well, yeah, they often overlook. So, well done. quite various governments to deal with, not on the national, but also regional, communal. Yes.
In Malta, we are well connected with the health authorities. So depending on which areas they are working on, we are usually called in to contribute by contacting the patient groups which are members within our organization. And then if we do not have specific patient groups, we sort of try to contribute from our expertise.
Okay, thank you. Any other? No. Okay, so Marta.
Yes. In Poland, there is Council of Organizations under the Ministry of Health and another one under Polish Ombudsman for Patients' Rights, and we cooperate with both. So, for example, if there's some need to discuss something, there's an urgent problem or something like this, you can, as a patient's organization, go to this council and cancel this meeting with Minister of Health experts, and we discuss this.
In Slovenia, we are mostly involved in local levels with our activities, but if something important will be from our side, we can reach also the national level.
In Ireland, it's getting a little bit more sophisticated insofar as that you have policy that's been decided to be implemented. So on the operationalization, on operationalizing the policy decisions, there's big efforts now to include patient advocacy in the design and rollout of that. Where I think the challenge is for the likes of ourselves, which is basically patients' rights, patient safety, that we are looking at the population and not a disease-specific organization. So you will see sometimes, say, the likes of the Irish Cancer Society develop. I mean, they are an exceptionally well-funded organization, but they will develop as professional a campaign as, dare I say, maybe you might put together, insofar as that they will engineer it to get at the media, to get at the people that are being affected by it, by the particular issue, and influence the political structure, not only at home, but also within the EU as well too. I suppose the good thing about in Ireland is that we have easy access to our politicians, more so than in other countries. So whether it's an MEP or even a minister or a TD, it is possible to get that access. So, for example, one of the things that we're doing now, we're still looking at a service level agreement with our main provider, will be to fill a role. And that's why I mentioned to Dr. Spinelli earlier on, we'd be, overseeing implementation of reform based on surveys that they do with the general population of patients as to how they perceive their experience. Now, and the reality of it is that Ireland, our health system, our HSE, when you benchmark it against industry, in other words, the Googles and the Facebooks and all the rest, they're down almost in 95th position out of 100. Yes, you have private operators that are in the top 10, on the reputational side, and that's an aspect that I don't think we look at as an organization, within the health system. So yes, there's an engagement on the operationalization of these policies, but when it comes to accountability, we don't have that in there just yet, and that's where your main lever is to challenge. So I hope that gives you some insight.
That's super helpful. And indeed, Ireland is one of the most transparent country when it comes to meeting with policymakers. I know because on a quarterly basis, I need to fill in the transparency form. But it's very interesting to see that most of you are not working only on the reactive side, but also on the proactive side, which is super important, simply because often policymakers simply don't know what they should do with a specific thing, with a specific issue, a specific matter, until the point that it's being brought to them for them to actually do something about it. Shall it be a legislation? Shall it be a guidance? Shall it be mobilizing different medical societies to do something? So thank you very much. Right now, I can adapt a little bit my presentation. So everything that you mentioned is exactly what we're doing in Brussels. So depends on specific project, specific strategy. We are adapting different messages to policymakers. And here on this slide, you see how the EU functions. We can write essays about that. We can have 5-hour lecture about it. However, the key point is that there are 3 main co-legislators. The only co-legislator that is chosen by the people is directly chosen by the people is the European Parliament. So here, I know that most of you were very active when it comes to reaching out to members of the candidates to the European Parliament, for which I'm extremely grateful. And this is, an ongoing issue to activate even more of us to vote and actually be interested in what the European Parliament is doing, because they're doing a lot. Everything that is being done at the European Parliament will impact every single citizen. There's a Council of the European Union. So here we have all 27 member states, and depending on the issue, they are meeting and discuss at the ministerial level. So all health-related matters are being discussed by representatives of the health ministries, decided at the national level, but then deciding at the European level. So that's very important to have national organizations whose messages are aligned with what the European counterparts are doing. So if you have a wonderful ACN being present in Brussels and there's specific legislation being discussed, it's very key to collaborate together, because the decisions are not being made in Brussels as to what specific country has to, what's their position. So how it works is that the ministry makes a decision at the national level, and then whatever the ministries will decide, the council will vote on. So it's really important. That's why I'm very happy to hear that a few of you are engaged both at the national level, but also in Brussels, because this is exactly how it goes. When it comes to the legislation, overall legislation, I would divide into 2 main ones: the legislation that is binding and legislation that is not binding. And unfortunately for most of us, health is not binding, which means that everything that Brussels is doing is not something that the member states are obliged to implement. It's just a kind guidance, kind ask, a nice request, but there's still a lot of work for us to do in Brussels, because it's a very interesting and useful tool to advocate at the national level. So if you have a specific provision, if you have a specific word agreed by the Council or proposed by the Commission, or even included in the report of the European Parliament, you can use it as a tool at your national level. So as you can see here, it's I will actually ask a question here. You know more or less how the EU is working. You've heard so many times about the European Council, Commission, Parliament. If you have a strategy to advocate, you have a specific issue that you would like to put in the legislation, where would you go first? Sorry?
National level.
No, at the European level. So if you would like to include something at the European level, if you have a matter that you would like to change at the European level, where would you start your strategy with? Parliament?
Ministry. To the group of the Parliament.
To the group of the Parliament. That's yeah.
That's it.
That's it. It's the Commission. It's the Commission. because everything that is created by the Commission is being sent to the European Parliament and to the Council. It's a second step. So if you have a issue that you would like to raise, you go to specific DG, so Director General responsible for specific, for health, for research and development, for different, depends on your ask. If it's skill workforce of the future, it's going to be employment. So you have to know who is dealing with a specific file. So first is the Commission. They are not easily accessible. So that's why the straightforward way is the European Parliament. But the European Commission is the one that where, first of all, they develop proposals based on scientific data. They have a lot of very brilliant experts that are working in the specific field that are technical, so to say. And if you have good messages, if you had specific matter that you would like the Commission to tackle at the European level, it's the Commission. Then, of course, there are different public consultations when you have legislation developed. Shall it be legislative or non-legislative file? The European Commission opens up a public consultation. So this is also an opportunity where stakeholders can provide feedback, but the European Commission also meets with people. So that's also your opportunity. If you have anything to raise, you contact the European Commission and they're obliged to meet with you. Specifically as an NGO, they will meet with you and they will hear you. Then after various rounds of consultation, bilateral feedback, meetings, a document goes in parallel to the European Parliament and the Council. Now, the Council usually doesn't even start officially working on that before having the report of the European Parliament because simply they have other priorities. But the European Parliament is quite, I would say, I wouldn't say easy, but there are 700 MEPs, and it's just quite accessible to meet with them, and there's a more transparent way of showcasing information from the European Parliament because each document has rapporteur, has specific co-rapporteur, so each political party has their own representative per file, and you have all the names, and that's why it's very accessible to meet with them because you know exactly who is working on that. You know exactly who's interested to meet with you. And the European Parliament would develop a report. Usually takes them, depends on the urgency of the file. The general pharmaceutical legislation, it took them seven months, and it was sped up substantially. But you see more or less how much time you have to actually provide feedback and make sure that it's included by the rapporteur, so the key person working on the file, and then you have every single member of the committee working on the file can propose amendments. So this is also a way to include specific provision that you would like to do. So it's quite relatively easy again, relatively easy because it's not as easy. But I would say it's easier to include specific provisions on your specific matter to the report of the European Parliament than it is to the Council. Because to the Council, if I'm based in Brussels, I can only meet with the representatives of the ministries to learn from them what are their plans, but everything is done at the national level. So if I would like to have, so there's also this very good application, Council Vote. I don't know if you know of that, but this is an application that is developed by the EU, so to say, that allows you to calculate the votes based on, because the weight of a vote per country depends on the number of citizens that you have. So it's a brilliant tool to use. But this is exactly how we are doing, just to see which country would block specific amendment proposed by the Parliament, which country would be opponent or rather an ally, so to say. But again, so that's why it's very important to have active organization at the national level, and also to be connected to the European ones. We can move to the next slide. Apologies. Right. So here I've just included a very simple chart. Just a few words how this chart is going. So if you look from the left side, that's the most left-wing party in the European Parliament. So you start with the left, then Social and Democrats, then you have Greens, then you have Renew Europe, which are more, well, it was previous ALDE, so liberals, that's the word I was looking for. Then you have European People's Party, more center-right. Then you have ECR, so conservative and reformist of the European Union. And then you have new groups that were created. Patriots was created by the famous or infamous Viktor Orban. And the Europe's sovereign nations, that's the newest one, that was created under the leadership of the German AfD. And the last one are non-attached. So you can see that there are more or less 33 members of the European Parliament that decided not to get any affiliation because none of the priorities of the groups reasoned with their values, so to say. It depends on the organization, but I can say that on behalf of RPP, we are not engaging in any of the extreme wings. So shall it be right wing or left wing? We are just trying to evade from that because everything that is extreme is not something that we'd like to get affiliated with. The upper slide is from the previous mandate. The below slide is the current mandate. And no, the EU is not spending more money on MEPs. We had Brexit in the meantime. Yes. So here the key takeaways here. As you can see, the biggest group is EPP. So the EPP that has a group that has the biggest majority when it comes to the outcomes of the elections have the possibility to put forward the name of their candidate, which is Ms. von der Leyen, who is currently, who has recently proposed her College of Commissioners, but we'll talk about it later today. So here, I've included key takeaways, but considering that there's what it means for us, what this election means for us. Again, we can have another 1 hour of the talk, but frankly, when looking at different priorities of different groups, health was not necessarily part of them. Of course, it has been included, but it was not the key the key matter that different political groups had at their forefront. So as we can see, everything shifted a little bit to defense. For example, the EU for health budget was also cut because we were looking at because the council, so the ministries, not Council of the EU, but European Council has made the decision. So the representatives of the states, or president, prime minister, depends on the system. They have decided to shift, to take 1 billion euro. I'm just looking at Mariano. They were looking for, but they were looking for 50 billion for defense. So as you can see, health was cut. And right now we are still going to fight for I wouldn't say for leftovers, but for what was rest from the European Health Fund. So here we've just collected different themes of different political groups, because right before the elections, everyone published their famous manifestos, right? So it was very important to analyze them and look into what is in there for health. And where we're looking at COVID and long COVID, and this is exactly where our strategy starts, because when you think about COVID, it's directly healthcare system, health organization, health prevention, but not only. At the European Union, we have to stay holistic, so to say, and look at other areas where we can realistically improve the lives of patients. Improves the lives of patients, not only of COVID, but also other respiratory cases, right? So of course, if you look at this, the biggest group, EPP, I'm very happy that they have strengthening of healthcare systems, innovation, digital health, but also they will be looking at workforce shortages. So it's good that the key group is looking precisely at health. But at the same time, if you look at the Greens F, I also have environmental health, right? They will be looking at changing a lot of air-related laws in order to improve the quality of air. And Renew Group has health crisis preparedness, but also when looking at COVID, we also can talk about cross-border healthcare. I mean, you remember very well that during the outbreak, it was key. So it was not working as well in Bulgaria. It was. Yeah. Exactly. So, but thanks to these directives that we have. So, when developing strategy at the European level, we often have to look holistically, and I think everyone is waiting for the European Commission to publish their first work program, where we will have the precise, where we have a list, and that's also maybe a cue for you, a clue for you. Sorry, not cue. Once it's published, have a look at different legislation and discuss internally if any of them is something that you would like to engage with, because I'm sure that your European counterparts will be able to help you with that. And my suggestion is not always to look at something that has health or preparedness involved, but really rather look holistically, because a lot of legislations are overlooked by health stakeholders. Even the biggest pharma companies, they are overlooked, and then last minute something is included by the council that makes no sense. So it's really important to adjust the work of your organization to different themes and different trends that and different revisions of different legislation that are there. And as an example, I will tell you one of the projects that I was working for or on still is the right to be forgotten for cancer survivors, right? That's the exercise that I did at the beginning. Realistically, I cannot change anything from health, right? But then I looked at the work program of the European Commission and I saw Consumer Credit Directive will be reopened. It was too late to engage with the Commission, unfortunately, because they developed it very quickly, but they engaged with the European Parliament together with the Belgian doctor that is pioneering this initiative. And in the end, we have managed to get it to the final text of the directive. Unfortunately, while in the Parliament, we have included 5 to 10 years for the right to be forgotten, because it was already a negotiation. At the council level, the trialogues, because the decision-making, it goes with the trialogues, 2 member states have blocked it. These are 2 member states where the insurance industry is quite big. So Germany and Austria, to be quite open. It's not a secret, so I can say that. But given the fact that industry is big, they put it for 15 years. But it's still a starting point. Right now, I'm waiting for the new Commission work program to be published. I'm expecting mortgage credit directive. But that being said, at the beginning, we were talking about cancer survivors, right? So health. But realistically, there are so many other legislation that you can use to change that. At the national level, I'm also looking at adoption, because the cancer survivors are discriminated through different ways of lives, and we have to evaluate everything. Here we've just put, I'm just looking at the time, that's to make sure not to overrun it. So here we've just put the key faces when it comes to the public health committee. So currently at the European Parliament, we have only one standing committee, which means a committee that can deal with legislative files, because all the subcommittees cannot do that. They can provide only opinions or ionized reports, so only initiative reports. But here it's the main committee so far. So as you can see, it was part of the negotiation processes. Who gets the chair? So this one was the socialists who got it. In the previous legislation, it was the left. Confin was the left, but then he moved to Renew. And the vice chairs are from 4 different political groups. So as you know from the previous slides, we have 7 political groups. No, sorry, 8 political groups. And why do I mention that? So there's a difference between chairing and coordination. Coordinators are for the entire group, which means that, for example, if I have an agenda to be put on a topic to be put on the agenda of the ENVI committee, I can go to the chair. I can go to vice chairs, of course, but actually these are the coordinators who are putting forward a topic for discussion on behalf of the group. So if I would like the ENVI committee to discuss the impact of air quality on respiratory cases, I would probably go to the EPP coordinator or some other bigger coordinator rather than the chair. But I would meet with chair when it comes to different amendments, when it comes to making sure that the vote will have passed. So again, each group has their own coordinator. but not each group has a chair or vice chair. It really depends on the outcomes of the vote. Sorry? Then briefly about SANS committee. SANS committee is a subcommittee has been created also in the previous legislature at the very end, and right now luckily we have, luckily or not luckily, depends on who you ask, because a lot of groups are not particularly fan of the SANS committees, simply because it's, you know, they believe that health should be part of One Health approach. There are gossips that the SANS committee will become a standing committee, so completely separate from ENVI, that will be dealing only with health files. Now, I've heard, I don't know what are the most recent gossips. Mine from last week's plenary was that the political agreement that they reached, they just slashed it, and there will be no standing, the committee will not be a standalone committee, but let's see. I know that Bianca will also be investigating Strasbourg. So here the same, we have chairs, vice chairs, and the coordinators. So again, depending on what you want to do, if you would like to put forward a topic on the agenda of the SAN committee, I would suggest going to coordinators. If you would like to if you would like to put amendments for your file, go with the rapporteur or shadow rapporteur of specific legislation. And again, just like with committees or subcommittees, each group has specific person working on a specific file. It's a must, it's a rule. But it depends, it's up to you who would like to engage with and who would actually listen to you. And yes, so that's the health committee. And just a question, have you at the national level, is it spoken about that there will be a specific committee on health within the European Parliament? I know the Polish news, some of them cover that, but is it something new? Have you heard that specific focus will be on health in the European Parliament? No. Oh, it's just a brief study that they wanted to do. But indeed, SANS committee is waiting, first of all, to have a political decision if they can be a standalone committee. But regardless, they are already preparing they're preparing their work plan, so to say. And we know that the very first thing that they have reached an agreement about is that they will be working on an own initiative report on workforce shortages. So this is exactly, the very first thing that everyone will be focusing on, because there's a lot of messaging about European health workforce, starting with a physical number of healthcare professionals that are out there for patients, but also discussing mental well-being. So there's how this report will look like, it depends on how active are European health stakeholders. So we'll see, but the timeline is for it to be finished by Q2 2024-5, if I remember well. And here we have I believe that this presentation will be shared with, so I will not go through this, but you will receive a slide deck where we just outline the key chambers in health from different countries. So we have Spanish, we have Bulgarians, we have Belgians, we have Croatians. Tomislav Sloko is one of the most active, still is. He told me that only last week he received around 150 requests for meetings, so still active. And this is where I stop. And no, do I stop here? No, I'm not really sure.
No, you should go.
I should go. Here, just again, we just prepared. So I've mentioned already that Ms. von der Leyen has built specific college of commissioners. Here you can find it online, so it's not really something that we developed, but each member state should have their own commissioner in Brussels. Now, after months of political agreement, she has decided who gets what. Unfortunately, health was received by the Hungarian candidate, and this showcased that health may not be particularly on the top of priorities of Ms. von der Leyen. We don't know if that person will pass through the hearings of the European Parliament, or they will decide to nominate him. it's to be seen. There are different theories out there. However, health commissioner is only one of the few commissioners that you can engage as an organization. I mean, there's a specific portfolio for crisis preparedness where, you know, a lot of messages from COVID can be shared with. There's also a quite good Bulgarian candidate that has specific level of experience in research and development, where this is also, you know, you can quite engage with. So let's see how it will go for when it comes to the election of the actual college. Here we've just included a very high level timeline, but where we are right now is that more than a month ago, the names were finally released with a huge delay from the Ms. von der Leyen. And at the beginning of November, the European Parliament will hold hearings. They will start on 4th of November and they will finish on 12th. And this is the time where each committee will be, I would say, interviewing different candidates for different portfolios. So the Hungarian candidate will have his hearing in front of Environment Committee, but also with the opinion of the Santa Committee. So we'll see if all candidates pass through. Probably we'll have a College of Commissioner in December. Often the European Parliament likes to reject one or two just for the sake of doing that, simply because they can. So it's also a political stance, and it may be expected that the health candidate will be rejected simply because he has no expertise in health, he has no expertise in animal well-being. On the top side, he is also he was a former commissioner. And this is where I give the floor to Luca.
Yes, just to be said that Ms. Oliver Varhey, which is the designated candidate for taking the place as commissioner, has already covered, as Kinga mentioned, the role of commissioner and as the commissioner for enlargement. He has not a background in health, but of course, since he has already been a commissioner, it will be hardly ever for the parliament to oppose him in nominating basically him as the next commissioner. Here we see basically possible like the priorities that have been set by the commission when it comes to different pillar for the next 5 years plan. As you can see, healthcare, as Kinga has briefly mentioned before, is missing. What we've seen that has importance for us today is the part on skills and educations that will also cover the part of workforce upskilling and also the ones, of course, the healthcare and medical workforce. So this will be a part of commissioner's priority in the next 5 years. And I think it will be also something that medical organization and patient organization can leverage once going to speak with political stakeholders, especially within the commission, trying to finding hooks that connect specifically healthcare and so the healthcare priorities with the burden of workforce that is a priority and it's an emergency all around Europe in this moment. Going to the next slides. So here it's the profile of the designated commissioner. As we can see, the priorities were not set as pillars in the main part, let's say, but the healthcare priorities are set in the mission letter. The mission letters are specific documents that goes directly to the commissioner from President von der Leyen, so the president of the commission, and basically they entails what is expected from each commissioners in their role if they are going to pass the hearings in the parliament. and what are the main priorities they should deliver immediately after they are taking the commission. So what we foreseen here is basically a plan to, let's say, finalize on different priorities that have been already set during the last mandate of the Commission. So to finalize, for example, the beating cancer plan, to also deliver on the pharmaceutical legislation that was in discussion from the President Parliament and that was delivered from past Commission. Also, this was a sort of political move from the Commission to not give too much of, let's say, of the possibility of the Hungarian commissioner to take political step that could have been problematic for the Commission. Also, it should be said that the portfolio of health priorities, so these are the main priorities right now, as you can see, is strengthening the European Health Union, availability of competitiveness and medical devices, European biotech and life science strategy. Especially this one is to be delivered by the commissioner working in let's say, in tandem with the commissioner on innovation and research, that is Mrs. Zarayeva from Bulgaria. So it's, let's say, it will be difficult also in that sense to find the proper person to speak with when talking about health, because the portfolio of health it's somehow split in different between different commissioners in the sense. So on the opposite side, this will make things, let's say, for the Commission easier because they will have more workforce inside the DGs to work and deliver on the files. But of course, from an external point of view, from external stakeholders, it will be a matter of difficulties to engage on the files that you will be interested in. So I think the most on the side of the European health strategy, the main point here is strategy for life science and advanced materials on Act that will also help delivering in the beating cancer plan, for example, and also in the cross-border prevention of infectious disease, because basically it also deliver on the stockpilings, for example, of medical devices and, for example, on the side of diagnostics when it comes to tests for COVID, but also for respiratory disease like influenza, etc. So I think this is a general overview. I don't know if you have any question or if, for example, from Bulgaria, you have already managed to have meetings, for example, during the past with Zarayeva. Will be interesting to know.
Okay, first of all, maybe I should tell to everybody that I'm a candidate for the National Parliament. The elections will be held on 27th of October. Second of all, this night I will meet one MEP who is a member of the Regional Development Committee. He is a very close friend of mine. It will be not that much work, but we will mention some points which are interesting. Third of all, yes, I know Ekaterina Zakharieva. We know from previous years through our work. She's very well known for her work. If you need any assistance by meeting with her, I could help with that. Unfortunately, beside of Stella Kyriakidis, because I had meeting with her, it was about the new cancer plan, and it was actually one day before it was represented in front of everybody. She actually made me her invitation to me to speak about all the priorities, and I thought that this will be the next Commission plans and strategies to continue. Also, the European Cancer Organization came with other people to speak about it. And when I understood about all those news about the elections of the commissioners, I was really bit disappointed, because I expected more about cancer, more about the prevention, about the diagnostics, about the reimbursements also, because this is very important topic, and maybe these will be the future points which we will speak about it with the next people.
I think that we were all disappointed when we were counting on Malta to have the next commissioner. I'm not as skeptical about the Hungarian commissioner, because he doesn't know a lot about health and nor animal well-being. That's another story about merging those two portfolios that I'm not particularly fan of. But it is what it is, so we have to work with that. On the other side, he used to be a commissioner, and he knows ins and outs of how the commission works. So I believe this is our job to educate him. Navigate him, but also educate. I'll go with educate, because some of them you just need to be educated as well. Not me. I'm not an expert. I'm just a connector. I call myself as a connector because I don't pretend to be one. I don't have any medical education, but I have people that I work with that are talking to different commissioner officials, and I think that he can do a lot of good the second that he's convinced and he knows exactly what to do, because again, the procedures of the European Commission are quite complex. So I think he can do more than the new candidates that has no clue how to navigate the system. So bittersweet. Let's see if it will come through in the European Parliament. And I think that's it. I mean, I think that we took more time than for but apologies for that.
No, it's fine. I think that it will be it was very useful and interesting. So that's why I let you go.
May I add something? First of all, thanks a lot. It was a great overview. That is a precondition for the ones that want to advocate at European level, to be informed, update about this picture, the situation, etc. The past legislative, it was the one that for necessity have take much more attention to the health condition of the citizens because of the COVID, because of the pandemic. Now the challenge is, it will be also this new mandate, not for necessity, but for choosing, for your decision. This is something which we have to push. The budget has been cut, so it's already an answer about our question, etc. But in any case, this is our commitment to try to encourage as much as possible the new elected member of European Parliament and the European Commission, etc., to take in consideration the health condition of the European citizens, that in the list shown by Luca, there was no words about it. In the priority of the moreover European Commission next 5 years priority, we don't find this aspect. Yes, just to finish, and then of course. But so we have identified the social rights in the pillars that Luca has highlighted, some aspect that could be represent the precondition to better protect the citizens' right, the patient's right, the condition of the health citizens, to empower and update the skills of the healthcare professionals is probably the better precondition towards more resilient healthcare systems, to better protect the patient's right, etc. In this context, we have imagined to draft and send a political document, an open letter devoted to the, and now it will be shown by Bianca, and also we have worked good together about it also with your contribution. But the sense is to ask to the European institutions to be much more engaged to provide up-to-date information, upskilling to the healthcare professionals as a precondition to better protection of the patient's rights. So this is the concept. And then we have produce document and receive endorsement, and we have a plan not to move on. I don't know if you want to react, or Luca, because Luca.
Exactly from this point of view, since we saw that it's not a priority for the European Union as it is, at least it's not set as a top priority, we should first of all do more on the side of the European Commission to have to prioritize let's say the upskilling of workforce and have less workforce shortages, but also in the implementation at the national member states of the priorities and the recommendations set by the Council during the last mandate. So it will be good, and we developed together a document that we will show you, and it's an open letter to the European Commission to really take care of these as one of the next priority on healthcare. And also to have member states accountable, let's say, maintaining member states accountable to the implementation of the recommendation of the Council in that sense. Thank you.
Thanks, Kinga. Thanks, Luca. Yes.
I've been thinking, like this issue of on the WHO level, they always say health in all policies. Would that work within the current situation, sort of like health and transport, health and youth, health and agriculture? I mean, or it would be just a wild goose chase on a European level, thinking in this way.
I'm just closer. I think it's doable. I mean, health is so horizontal, such a horizontal issue. I mean, of course, right now in the European Parliament, we focus on one health approach, which is animal health, environment, and human health. But if you look at any single other sector, it is important. I mean, health. I take into account, for example, framework when it comes to the time in the day where airports can fly. The noise pollution on human health. That's transport, that's aviation. Same for general aviation. Same with drone framework. It's also noise pollution. It's a health hazard. If you take into account agriculture, huge impact on human health. Crisis preparedness, equality. I mean, gender equality. Again, a lot of work for health stakeholders. So I think that the challenge that we have is that we have to simply choose from the different things that we can do and develop the most impactful strategy, because other than that we just have too much work. We just don't know where to go. But environment, employment. So what we as healthcare consultancies are following is of course anything related to health, anything related to agriculture, and we are also following sustainability in healthcare, which is also a very important topic. Mental health, which is also that's a new relatively new topic after pandemic, but also gender equality as well. It's women empowerment as well. Also looking at women's health that somehow was under the scope of the European policymakers. We are not trying to say that women's health is not important, but there is a huge problem when it comes to the participation of women in clinical trials, looking at different unmet medical needs of women. So yes, we're looking at employment policies as to what's the approach of the European policymakers when it comes to making sure that women's needs are addressed in the employment policies. So yes, to reply to your questions, WHO, I agree with them. And in every single sector, there's an importance to consider health. Yeah.
Thank you. I'm sort of thinking sort of tongue in cheek, but also like from a strategic point of view of leveraging issues within the current commissioner, if, you know, it all comes to fruition. And that is the fact that, to me, a weakness in it, as I think you already pointed out, is the fact that you have animal welfare and human health in the same portfolio. Because I can tell you that there are patients if I hear about benefits that are being given, better benefits to animals than patients that are in need of care, that's going to create a problem. And perhaps then you will also have the lobby for animal rights, is very much their entitlement to do, that will be pushing for their particular agendas, and probably will be quite happy to see, you know, animals equated. Like, I'm just thinking, you know, the way these arguments can run. And I think that that would be something that I think the likes of yourselves or other experts could keep a very close eye on, as to what legislation is happening in the two pockets of the same game. Because if it does, I mean, jokingly in Ireland, you'd often hear that animals are treated better than patients. You know, they can get to see a vet. There's empathy with the owners of the pets and all this sort of thing. Do you know what I mean? That they mightn't experience with their family GP or whatever. The other quick point about the workforce planning, right, which is really, really important. There's huge barriers there of resistance within the professions themselves. As, for example, a number of years ago, the healthcare assistants were regulated. You know, you had healthcare assistants and cleaners and porters and you know, people working the food, the canteens, and they became regulated. So therefore, they became specialists in their own particular area. But then there are ones that were dealing patient facing, and they were then saying, we can take a patient's blood pressure. But the nurses were resisting it because that was part of their turf. But the really big change is, and I'll declare an interest, I'm involved with them, the Innovation Value Institute, which is an academic stroke industry involvement in the whole area of developing AI and technology and so on. And it has its own manifesto, and I'll be happy to share it with you. But we tend to be looking at manpower planning with the old perspective of, you know, we need so many doctors for so many patients and so many nurses. But the whole strategy within the next few years is what they call shift left. You want to keep people out of hospitals and keep them in the community to look after them. And for that to be delivered, you're going to use technology, and pretty smart technology. You already have it on your watches and so on. So I just caution about saying, yes, we want to, you know, get the numbers, you know, get the numbers for all the allied professions involved, but nobody has really factored in the fact of the impact of AI, both on administration and within the actual professions themselves. It's in, you know, within 5 years, you're going to be sitting around a table like this and you'll be saying, my God, what happened here? It's that fast, the way it's coming, you know?
I think these exactly resonate on what we are working on, different set of projects to connect and let's say to align the workers and see how to manage technology inside to help workers work better and more efficiently, let's say, but without let's say having those workers out of the job market in that sense, because this is the pushback from many categories, and we need to find a good balance to have technology well set and used to better implement and help deliver better health services to patients, but also maintain a balance within the workforces, nurses and doctors in that sense. And I think the Commission, it will be very happy to hear from a different set of stakeholders, especially patients organization, but also medical organization, to see how to, let's say, how to put up recommendations to member states on how to enforce those new regulation around the use of, for example, artificial intelligence and other type of automatic technologies in that sense. So there is an open.
Yeah, just to maybe give you. So this is exactly a topic that was identified earlier this year, and you can follow on LinkedIn. There's a working group called Capacity Enhancing Innovation. And that's exactly what they're trying to do, optimize the current system and not looking at then the raising of numbers of healthcare professionals, but how to use the existing technology, engineering. So there's a big group of stakeholders who are working precisely on that, on
capacity enhancing innovation.
You know, the name could be better. But yes, they are available. I mean, they launched their LinkedIn profile. So capacity enhancing innovation, that's good to follow.
So, thank you very much. There's a small change into the program, just because I want to keep the momentum, and so just spend a few words on the document, about the document Luca and Kinga just mentioned. So just let me, oh my God, where is it? Wait, I just have to find how to share my screen. Yes, okay, sorry. Okay. So most of you already know what we are talking about, because most of you already gave inputs and the endorsement from your association to this document. But for the sake of clarity, I would like just to tell something about the context in which we developed this document, because as you all know, we've been always been committed to ensuring that the right to health of European citizens is protected. And in recent years, we have also been working hard to help keep the focus on the health workforce crisis in Europe. And that's why we dedicated the 2024 celebration of the European Patients' Rights Day to the key role of the healthcare professionals. Because the pandemic has exacerbated existing problems such as job strains, skill shortages, medical desertification, and raised new challenges, such as how to better prepare for future health threats. And so, as a follow-up to the 18th European Patients' Rights Day, we decided to draft an open letter addressed to the new European Health Commissioner to ask to prioritize the health workforce crisis by implementing a series of concrete actions. So as I was saying, the letter was written with the support of the RPP team and taking into account, of course, the comments of the associations that have already given their endorsement, which I just want to show you, because so far we received the endorsement of 28 national patient advocacy groups from 15 different countries. But also we started to collect the endorsement of other kind of organizations, so European umbrella organizations and associations representing the healthcare professionals. And so, so far, these are the associations that gave their endorsement to the document. And so our intention is, after this phase, also to present the document to the members of the European Parliament. And of course, we're working hard to do so, but your help is very much welcome and appreciated. So that we will be ready to address, to send the letter to the new health commissioner as soon as he's nominated. And so we plan to do so. We plan to publish the letter with the list of endorsers in November, but of course we have to adapt the timing. But of course, most of you already gave the endorsement, but in case you haven't done it yet,
Please show again the
hope,
list.
yes, we hope
Very
you will endorse it.
If
But
you don't find the name of your organization, please let me know. You are not interested to endorse, or
let
if
me,
you are still on time to add the name of your organization.
yes,
So
but
from the Plataforma Organización de Pacientes, Manuel. No, as because already Manuel already endorsed as the ALCHER, the National Association from Spain, etc. So we are confident that we can also add the name of Plataforma within Friday. Within Friday, yeah.
And Ireland too.
And Steven as well.
I'm searching for the letter.
Okay, we need this. Can we find also your organization? Can we add as well? You have to check. Take your time to.
Well, you don't have to answer now.
And probably from tomorrow morning, we are waiting your final decision. Feel free.
With bated breath.
Okay. But it's no. So this is some, but it's important for us because it's important that it will be heard the voice of as much as possible associations, starting from the ones that have also some concrete contact with the new elected member of European Parliament. So now,
yeah,
starting also from your suggestion, can you please help us to identify some member of European Parliament in which you are already in touch? Please.
We are all looking.
This is a very the advocate.
Printed this night, you sign. I'm pretty sure.
Yeah, we will have
Yes,
time.
right.
No. We will have time to speak
Okay,
about it
but this is
later.
important because we can also imagine to come together to meet him. This is something that we can plan also.
We are listed today as an organization. Yes. I just saw us. Yes. Well, Peter Ajus accepted. Yes. And Alex Ajus Saliba, we also have contact with him. We've communicated more on mental health and pain, but so 2 out of 6 from Malta. Who is going to beat us?
So, really,
Jasna from
thank you.
Croatia.
Yes. No, well, we already spoke about something earlier.
For
Yes.
sure.
Yeah. No, but you know what? As you were saying, and also as Kinga mentioned earlier, we already are in contact with MEP Sokol, but
We are in the waiting list.
yes, because probably he's overwhelmed by emails and meeting requests and so on. So yes, if you can.
You can facilitate. You can facilitate. Yeah,
Okay.
thanks.
We have three names. We have three names. One is Dolores.
Okay, wait. Keep them, and just after I will take notes from all of you, just because I don't want to run late, and I would like just to give the floor to Joanna and Mita. But first, before that, please let me thank you again, Kinga and Luca, for the very interesting presentation. Please.
Thank you so much. Let me just pull up the slides. Sorry. Yeah.
Oh, yeah, sorry.
Here we go. Okay, so in the name of time, I will be quite quick with this one, just so we can make sure we have the most time for the sort of filming element of this. But first of all, I'll introduce myself. So I'm Joanna Muller, and this is my colleague Mita. Lovely to meet you all. A little bit about our objectives for today. So first things first, I will talk a little bit about the campaign that we plan to run as a result of this workshop and of your letter to the Commission. We'll also capture some content, which I'll tell you a little bit about shortly. And then tomorrow we'll tell you a little bit more about our successful campaign last time with the vaccine action side of things. So you'll likely remember from last year the Care for All campaign that we ran to draw attention to the need for improved healthcare investment, training, prioritisation of COVID-19 in healthcare policies. Oh, it's just popped out at the bottom. Oh, no, that's okay. The campaign ran from last year, 2023, up until 2024, and we got lots of engagement across X, formerly Twitter, and LinkedIn, just kind of further bringing to light the cause that you're all working towards. In fact, actually, one of the posts from that campaign gave the highest level of impressions and engagement of any of the campaigns we did. So people are listening, people are seeing what you're doing. So to build on this year's key asset, the EU Commission letter, we've transformed this into a kind of public-facing document for the sort of interested public to get involved with. We want people to see your cause and sign up to it and put that additional pressure on those in power. But we will need your help to amplify that campaign and move a little bit closer to the microphone. We will need your help to amplify that campaign and kind of show it to people in your regions and sort of share that further. And that is where you guys come in. So we know that people are interested in people and what experts like yourselves have to say. So we would like to capture your thoughts today on this Commission letter, sharing little lines from the letter itself. Some filmed, some will be sort of static quote cards, as you might have seen on the ACN's LinkedIn before. We will ask each of you to both take part in a statement across the board, so each taking a short snippet of an overarching statement, which will be in total. So we call on the new EU institutions to address the health workforce crisis by supporting the knowledge acquisition and upskilling of healthcare professionals to better protect the rights of patients across Europe. And you'll each get a statement as well yourselves, which we can talk about. I know some of you have already given us an idea of the ones you're interested in. Other than that, we can discuss when you come next door for the filming. Finally, a little bit about timelines. So obviously the workshop is today. We'll capture the content today as well, and then we'll work behind the scenes to make that look all presentable and ready for social media. And then that campaign will hopefully go live across November with time to reflect in December. A little bit on the video and photography side of things. So we'll capture that footage today. And the purpose of this is to build that campaign content, as I said. But I know a lot of you have already signed the release forms that went around earlier. If you could bring those in next door when you come for your filming, that would be much appreciated. And I will pause there. So in terms of what we do now, we have a little bit of time. Maybe we start, Stephen, with you, just because you're first on my list on here, I believe, on the statements, and then we can maybe work around the table. Nita and I will go next door and be ready for you. If you could just come back in once you're recorded and ask your next person to come through, and we'll get you done. A lot of you we've met before, so we have headshots already, but those that we don't, we will take those as well. And I will pause.
One point, the campaign is in coherence with the message of the open letter.
Yes.
The open letter is more devoted directly to the European institution, but the content of the communication campaign is the same. We have selected some key messages from the document that help us to draft the open letter. We have selected some key messages. This is also in coherence with the last year communication campaign already shown by Joanna, in which we have enriched the constituency of the patient advocacy groups involved. There are also the collaboration of RPP, the support of Pfizer, and our initiative. So, but the difference is that we don't use anymore some actor as a picture, but each one of us is the champion. So this is important because it adds value to reinforce the commitment of each of us in front of the institutions and the ones that are at the target group of the campaign. So this is important. Thanks.
Wonderful. In that case, we will head next door, and Stephen, if you would mind come with us, and we'll crack on.
Okay, thank you so much. Because the guy was, yeah, but he left.
Okay. Al microfono. Okay. No. Okay. When we are all together, etc. I don't know if someone connected want to interact or something, because it's important also from our side to know your point. I know there was also someone, I don't know if Anna is still connected from Spain. I don't think so. Irene, if you wish.
No, she. So I just would like to thank again all the people who were connected remotely. And thanks again, of course, to all of you in the room. And so I hope to see you see you tomorrow. Thank you again.
Bye.